The causes of empyema, 50% have secondary to the pulmonary causes, either due to pneumonia or suppuration of the lung, due to the leakage to the pleural cavity, or maybe as a complication of septicemia. This is another focus of infection, either in the liver or in the spleen or anywhere in the body, lead to by blood transmission, lead to the coming to the pleural, lead to the formation of empyema. Mediastinitis, this is due either iatrogenic during treatment of the foreign body, doing an oesophagostomy, lead to the perforation, or maybe due to the trauma to the esophagus, or maybe sometimes due to the lead wing angina. This is a retropharyngeal abscess. Retropharyngeal abscess may be leakage to the mediastinum, lead to the, after that, lead to the pleural, lead to the lung empyema. Or maybe post-operative complication due to the thoracotomy, an infected one, maybe they have post-operatively, or maybe have penetrating injury either by stab wound or by bullet injury or shrapnels. These are maybe have a soiled material coming inside the pleural cavity to lead to formation of the empyema. Sometimes this is from outside of the lung, coming from the subdiaphragmatic, especially in liver abscess lead to the perforation of the diaphragm coming to the pleura. And the most common causes of the bacteria that affected of the empyema may be due to the pneumococcal or staphylococcal or anaerobic, either E. coli or Klebsiella we have, or Pseudomonas. This is a photo, you can see it. This is a normal pleura on the left side. On the right side, you see there is a pass between the chest wall and the lung. This is what we call an empyema. Now, on examination, the patient have febrile, toxic, and shortness of breath, besides chest pain, pleuritic type, cough, and when you put your stethoscope, it will have a decrease in air entry. How you can diagnose that one? By a proper check of history. Beside that, you do a chest X-ray. Don't forget, in chest X-ray should be in two view, PA and lateral. And we can do an aspiration of pus for culture and sensitivity, or for the acid-fast bacilli in suspicion. Sometimes we can do also for cytological study. Bronchoscope to exclude the foreign body, or maybe due to the tumor. This is always, it is important to do a bronchoscope. The most important of the treatment, it is the bed rest and a good nutritional status to build up, to change from the catabolic phase to the anabolic phase. And you should be given an injectable antibiotic, and you can do a thoracentesis, or we can do a tube thoracostomy. Only in case of the TB, always you should be do a proper anti-TB medication beside a thoracentesis. When I can do a chest tube or tube thoracostomy in TB, when it is have a thick pus, or maybe a rapid reaccumulation of that one when I do repeated thoracentesis. Chest tube, if occur, maybe either it will be do it under a closed or open. What I mean closed, I should be put it in under water seal. This is what we call it, a chest drain system, ICD chest drain system. This is under water seal. Or sometimes when you have what we call it fibrotic lung. This is interrupted lung. We can change it to the open. Yani no need to put a chest tube underwater seal because it is an closed compartment because of the fibrosis. There is no recurrent attack of the pneumothorax. Don't be afraid about pneumothorax because this is what we call interrupted lung. This is we change it to the open. Change it to the open drain. This is what we mean close. A close mean you should be connected the chest tube to the underwater seal open. No need to put it in underwater seal either by connected to the urine bag or even you keep it with the dressing only, put a gauze on it. If a fistula formation, bronchopleural fistula, you should be do a thoracotomy. This is on the left side, the chest X-ray. See this a whitish shadow. This is a collection of pus, and this is the procedure we do it. We do it thoracentesis. Always you put in knee elbow position, sitting position the patient, and you go to the inferior angle of the scapula. You can injected your needle to aspirated one. This is as you see it. If it is a thick one, or a large amount, or rapid accumulation, you can do a tube thoracostomy. This is, you see the pus drainage in kidney dish. Complication of the EMPYEMA, a serious one when you have a bronchopleural fistula, or maybe affected the chest wall. This is what we call it EMPYEMA cystitis, or maybe going to the pericardium, lead to the pericarditis, or maybe lead to the mediastinal abscess, or maybe go to the esophagus, leads to the broncho or pleural esophageal fistula, or maybe eroded because of the chronic infection, maybe lead to the eroded of the rib or the sternum, lead what we call it the osteomyelitis of the ribs or the sternum, or maybe have a TB pleura. Pleura either affected by TB, or sometimes the TB affected the bronchus, which is the worst thing one, or maybe affected of the parenchyma of the lung. A chronic EMPYEMA. Why it is occur we have a chronic EMPYEMA? For always your best treatment and your goal of your teammate to keep this acute phase, and you should be completely eradicated of the acute phase to prevent to change from the acute to the transitional and to the chronic one. By what? By a proper history and diagnosis and the proper treatment of that one. Besides that, you should be keep the patient under observation to complete eradication of this EMPYEMA. After that, it will be lead to the cure of that one. But sometimes you give a proper things, but you have some mistake because either a shortage or a deficit in your equipment, like you have a small size of chest tube. When you put a small size of chest tube with a thick pus, maybe it lead to the obstruction of the holes of this tube, and you thought there is no more drainage, and you remove the chest tube, but still the pus inside one. This is a wrong thing. Lead to the formation of chronic EMPYEMA. Or sometimes early removed of that chest tube maybe also lead to development of chronic EMPYEMA. A TB pleural, this is always lead to the chronic one. Or when we have a bronchopleural fistula, we have development a chronic EMPYEMA. Before deciding of your treatment, you should be treated the underlying cause to prevent any recurrence of the EMPYEMA. Now, after bed rest, good nutritional status, thoracocentesis, a tube thoracostomy, either closed or open. Maybe you change another step of your treatment. This is what we call it a decortication. There is a two term you should be differentiated. Decortication means I do a peeling of the infected pleura. Peeling معناته تقشير decortication. But another term we call it a pleurectomy. This is also peeling of the pleura, but this is not infected pleura. So you should be know pleurectomy, I remove or peeling of the normal pleura. This is when we have a spontaneous pneumothorax. I do this procedure. When I have empyema, I remove the infected pleura, that we call it decortication. If it is still after decortication, there is no expanded of the lung, no expansion of the lung. So I do then thoracotomy, I do lobotomy, or maybe I do bilobectomy, or maybe I do pneumonectomy, remove all the lung. And this is what we call it a pleural pneumonectomy. Sometimes even I do this, and I remove all the lung, I remove the lung, still the space and drainage. I do another procedure. This is what we call it. Either I do partial thoracoplasty or complete thoracoplasty. A partial thoracoplasty is divided to two things. Either I remove upper 6 ribs, or lower thoracoplasty, I remove lower 6 ribs. A total I remove 12 ribs. 12 ribs. يعني لما أني بالثoracoplasty ليش يعني I remove the all the ribs. I will lead to يعني reduction of the space. I make the anterior chest wall close to the posterior chest wall because there is no rib. So it will be lead complete obliteration of the space by the anterior chest wall and posterior chest wall. This is what we call it a thoracoplasty. This is sometimes the patient, he refused the surgery. And when I do an open a tube thoracostomy, still leakage, I do the patient, either he will unfit for the surgery or refuse the surgery. I do a rib resection. This is a local anesthesia. I open a small window on the rib, I open the skin, subcutaneous tissue, and muscle. When I reach to the ribs, I remove the periosteum of the ribs. I cut the ribs. It will be a painless because the periosteum only the painful one. When I cut the ribs, after that, I inverted the skin, the upper edge or lower edge inside the pleural cavity. This is what we call it a rib resection. I do it as we see it in this photo and diagram below the chest X-ray. Now, another pathology we have, what we call it in the pleural, we have a chylothorax. Chylothorax, it is accumulation of the lymphatic fluid to the pleural space. This is a thoracic duct originated from the cisterna chyli in the abdomen and passed through the diaphragm with the aorta at the level of T12 and go to the chest to terminated to the near left jugular subclavian junction vein. And what have the causes of this chylothorax? The most common is a trauma. Second one may be neoplastic, or maybe have a congenital anomalies of lymphatic, mediastinal, or in the lung. Either we have lymph angioma, we have, or we have also thrombosis or obstruction of the superior vena cava, or may have a rare pulmonary lesion that permitting lead to the retrograde of flow. Thus, in cases of the TB, or maybe a newborn resulting from the injury at birth and the complication of that, or we have congenital lymphangiectasia of the lung or a pleural. Now, how I can differentiate it from the empyema, Kylosaurus? It is when I do a thoracocentesis aspiration, it will be have a milk-like materials. It is not a clot. It contains a fat and fat-soluble vitamins. Besides, we have a protein and antibody inside this. Otherwise, in empyema, only we have a pus, a fibrous tissue, and we have either a lymphocyte or we have a neutrophil. Here we have a fat, a vitamin soluble, and also with that we have a protein and antibody. How you can treat it by one? This is by low-fat diet, and you should be give يعني a medium chain, a small chain of fatty acid, not a long chain of fatty acid. And you should be do also tube thoracostomy, close one, and the most important, a nutritional supplement. Sometimes, if it is still leaking, we do a thoracotomy. Before I do a surgery in the day and in the morning of operation, I give some piece of bitter زين يعني زبد or oily materials like olive oil to take it. When I do a thoracotomy, it will be leakage from the site of the يعني trauma of the thoracic duct, so I can identify it when it will be dropping or leaking. I either close it or ligate it. This is how it will be appear like milk-like appearance. If you compare it with the previous syringe, it will be have a green-like. This is it will be milk-like. Now, also we have a primary pleural tumors. The primary pleural, this is a rare one, arise from the cell from various elements of the either visceral or mediastinal or diaphragmatic or parietal pleura, and any part of the pleura, either visceral or parietal one. As you know, the parietal one either affected the chest wall or the dome of the diaphragm, or also affected in the pleura or mediastinum, and maybe any part of that one lead to the primary tumor. It will be either we have a fibroma or fibrosarcoma, or maybe have a mesothelioma. This is a mesothelioma. Either it will be a localized or diffuse. It will be different in the presentation if it is a localized or diffuse. This is it will be affected the young age, and the slow-growing tumor, large size with metastasis, and asymptomatic or symptomatic, discovered يعني accidentally by chest X-ray, but the complaining maybe it is not related to the lung. Either we have a pain, a swelling of the various joints, or maybe have a finger clubbing, arthralgia, and fever. This is what we call it pulmonary osteoplasty, pseudopulmonary osteoplasty. And rare we have a bronchial symptoms because it is in the pleura, not in the parenchyma. Rarely you have a cough or dyspnea or fever or chilling. So always it is difficult to discover of this because it is beside of the pleura. It's difficult to the diagnosis of that one. So, but diffuse it will be have no chest pain, not like one that, and dyspnea more, weakness and weight loss, and sometimes you have hemoptysis because it is a diffuse, not a localized tumor. How we can diagnose this by chest X-ray? Two of you don't forget, and we do a bronchoscopy, And the most important, your diagnosis, it will be a pleural biopsy, and a CT scan is very important to confirm your diagnosis. Treatment: a surgical excision followed by deep X-ray therapy. A metastasis from the lung, breast, and lymphoma is more common than the primary one. And treatment: if we have metastasis to the pleura, it should be treated by deep X-ray therapy, and we have a cytotoxic therapy beside hormonal therapy. These are regarding the EMPYEMA. Now, let we go to have 1980 attempt of the lung transplantation, uniformly better at that time, but before it, the kidney transplantation, even the heart transplantation have done a lot of job before the lung transplantation. Still, we have either we do a single or sequential, mean bilateral lung transplantation. Can I do a single only one lung transplantation or sequential? يعني both lung transplantation, or sometimes we have what we call it pulmonary heart transplantation. We took a both of the lungs and heart, especially in Eisenmenger disease. This is only to know the historical of that one. And, and this is the Mr. James Hardy, the first one he do in 1963, lung transplantation, but this patient stay in the hospital 11 months when discharged. After 1 month, he collapsed and died. Now, what are the indications for single and bilateral transplantation? This is, you should be remember it very well. First of all, we have end stage of pulmonary fibrosis, or we have then COPD, chronic obstructive pulmonary disease, or we have a pulmonary hypertension, either primary or secondary due to the Eisenmenger syndrome. Maybe you have unilateral end stage lung disease like in sarcoidosis, or we have leiomyomatosis, or we have eosinophilic granuloma, or maybe you have a chronic pulmonary sepsis, cystic fibrosis, or severe bronchiectasis, or maybe you have emphysema due to the alpha-1 antitrypsin deficiency, or sometimes a controversial about reimplantation of a chronic rejection systemic disease with a pulmonary interstitial lung disease. يعني هذا المريض غير يستهلك رئات، يعني هذا مو كل مره نسوي له لانج ترانسبلانتيشن تعال عيد له مره ثانيه، عرفت شلون؟ هنا الا اللهم تتدخل به الكوميرشال، يعني المسائل الماليه وشغلات الانسان مرات يجبر الجراح انه يسوي له another reimplantation of the lung if it is a failure one. The procedure of lung transplantation, first of all, you should be first anastomosis of the lung. يعني it is a tracheal anastomosis. Second, you should be treat start to suture of the common pulmonary artery. And third one, you can have a cuff of the donor left atrial containing pulmonary veins. يعني انت من تاخذ اللنgs from the donor to the recipient, you should be cut a part of the left atrium that contain the pulmonary vein to re-anastomosis with the left atrium of the recipient. And first of all, you anastomosis the bronchus and pulmonary artery. Later on, you anastomosis pulmonary vein to the left atrium of the recipient. Complication of the unilateral or lung transplantation: bronchial stem fistula, this is a serious one, or maybe have emphysema, it is not inflated the lung very well, or maybe have infection. By the time, because of the increase the knowledge of the anastomosis and lung transplantation, we see what is the wrong by anastomosis, what the problem by anastomosis, why the patient have rejection or not rejection. It is improved our knowledge about the transplantation, so the mortality rate, it will be decreased only to 2% now. Previously, it is more than 25%. Now, this is because of the development of the good lung preservation and better management of the infectious complication and early recognize and promote treatment of acute rejection. Now, these are the selection for recipient. يعني علما أني أنا أسوي له recipient one, which one he need. First of all, it should be young age, يعني below 60 years, because a life expansion, it is more than 2 years or 30 years, 20 years or 30. Don't choose يعني a lung transplantation for old age. Always preferable to do it for the young age, below 60. When it needs a steroid treatment greater than 10 gram of the prednisolone per day and continuous, not milligram, 10 gram of the prednisolone per day, continuous, relative but not an absolute contraindication. And the clinical and physiologically severe disease, it can limit it of the life more than 1 to 2 years. يعني لما تتوقع هذا المريض ما يقدر يعيش إلى سنة سنتين، هذا a good candidate for the lung transplantation. And medical therapy, it is ineffective or unavailable. يعني نوصل إلى حد إنه شد ما تعطي من علاجات بدأ يستفيد المريض، أو بعد ما موجود هذا العلاج اللي يستفيد منه المريض، لذلك تخليه candidate for transplantation. And when have, it should be adequate left ventricular function without significant coronary disease. يعني لما تاخذ المريض يعني only have a lung problem, not have a comorbidity for other, he may be dead after the transplantation due to another cause, not from our procedure of surgery. Should be the patient ambulatory with a potential for rehabilitation. and ما اخذ لي واحد crippled on the wheelchair لا يتحرك ولا يقدر يستفيد من اللانج transplantation. It should be have a good ambulatory and have rehabilitation، يعيش حياته بالشكل المضبوط أهم شيء بالنسبة لي. and should be have acceptable nutritional status of ideal body weight. يعني لا تخلي المريض كشكسك because any كشكسك maybe it lead to the rejection of the donor يعني lung. And lastly, be satisfactory psychological and eco-emotional of that patient. يعني أنا ما أخذ لي اليوم أنا أسوي لي ترانسبلانتيشن للمريض يقعد يفكر ها أنا ما أخذ رئة فلان، أنا أخاف ما أقدر أتنفس مثل ما هو يتنفس، أخاف هو ياخذ هواء أكثر مني وأنا ما أدري شنو، أو تلقى إنه psychological upset وتلقى هذا المريض يعني يضرب أخماس في أزداز. هذا المريض keep it away, don't put it on your list. الدونر سelection احنا لما ناخذ مين ناخذ، يعني من يا مريض ناخذ له. يعني اول شيء after brain death in the lung it should be have a clear chest x-ray and the dimension of the size and matching of the body weight with the sex. يعني هنا الهارت transplantation, kidney transplantation, liver transplantation, any organ transplantation, يعني it's not important in unisex, but here it should be in the lung transplantation, it should be the same sex. يعني take a lung of from the female to the female, from the boy to the boy, and from adult to adult. يعني ما اخذ لي رئة يعني child for the adult or بالعكس اخذ لي رئة يعني adult to the child. Always it should be a body weight and height and sex. Second, it should be the lung of that one, the arterial oxygen tension exceeded 300 millimeter with the FiO2 and 1 liter to 5 centimeter of positive and expiratory pressure. and to keep the lung and always to prevent any atelectasis, and it should be a residual volume high to prevent any atelectasis of that one. Bronchoscopy should be do it. We have no cross-purulent secretion and suggestion of the aspiration, and it should be 6 hours or less of the ischemia. يعني ما تعطل أكثر من اللازم، لأنه اللانج مالتي يعني إذا المريض أنه صار ischemia and during 6 hours I should be take it. And beside the most important the ABO compatibility and the HLAB should be matching. should be matching should be matching. عادة يعني في دول العالم باليابان يعني ياخذ الابن من الاب او اي واحد يعني من العائله يعطي يتبرع بجزء من الرئه مالته يصير باباتي. This is either we have sequential lung transplantation, mean a bilateral. This is the way to lung preservation. It is not important for you, only for your knowledge. It is not important to يعني take it in your mind, only for review of your knowledge. This is how we can do anastomosis. First of all, we can do anastomosis of the trachea. Later on, we do pulmonary artery, and last one we do left atrial appendages. This is always you should be put post-operatively on the immunosuppression, cyclosporine, azathioprine, or prednisolone. And the preoperative you should be do the anti-lymphocyte and anti-thymocyte antibody, and you should be given azathioprine 2 milligram per kg IV in 1 to 2 hours before your induction of the anesthesia. And post-operative, this is that you see it, Babati. This is the procedure we can do it. Trachea, artery, and vein. This is the pulmonary in the left atrium. This is you should be know the diagnosis of acute infection. It will be decrease the arterial oxygen and pyrexia and decrease exercise tolerance, and it will be have fatigability and radiological infiltration of hilar, and 97% occur in the first 3 weeks. It should be treated by 500 to 1,000 methylprednisolone IV, and you should be take a transbronchial biopsy. This is a result of lung transplantation. It should be have survival more than 84% for 1 year and 81% for 2 years, and the hospital mortality only 6%. The causes of the early and late death. This is how we can preserve the lung, Babati. Thank you very